I am Dr. Charles Faiman, the chair of the virtual Grand Rounds sessions on type 2 diabetes. I am a former chairman of the Department of Endocrinology, Diabetes, and Metabolism at the Cleveland Clinic and currently a consultant in the department. This is the fourth lecture in our third season of CME-approved, case-based management presentations dealing with type 2 diabetes. As emphasized in previous presentations, type 2 diabetes has become a major healthcare issue in both this country and the world at large. The most recent estimate is that almost 26 million, or over 8% of Americans, have diabetes. And it has been estimated that 35%, or 79 million Americans over the age of 20 have prediabetes. This condition carries with it an increased cardiovascular disease risk. The current healthcare burden for diabetes in America has been estimated to approximate $200 billion annually. Clearly, today's topic of early, aggressive treatment of type 2 diabetes is timely. The rationale behind this approach will be discussed. The earlier introduction of more than a single agent with complementary modes of action will help to reach and maintain therapeutic goals. Moreover, the earlier attainment of these goals should promote an increased confidence level among practitioners and lead to better outcomes for the population at large. It is my pleasure now to introduce today's speaker, Dr. Derek LeRoith. Dr. LeRoith is currently Professor of Medicine and Chief of the Division of Endocrinology, Diabetes, and Bone Disease at the Mount Sinai School of Medicine and Medical Center. He is a past Chief of the Diabetes Branch of the Institute of Diabetes and Digestive and Kidney Diseases at the NIH. Dr. LeRoith is well recognized for his major contributions to the literature on diabetes, has received many awards, and is a frequent speaker at local, regional, national, and international events. Dr. LeRoith.
Hello, I'm Derek LeRoith, Professor of Medicine at Mount Sinai School of Medicine in New York. I'm going to discuss today the early aggressive polypharmacy in type 2 diabetes. The case we're going to look at to start is a 42-year-old man with a BMI of 34. He admits avoiding going to the doctor, presents for a new consultation after his older brother received a diagnosis of type 2 diabetes. When he was questioned, he mentioned that he had increased fatigue. His blood results showed a hemoglobin A1C of 6.9% and a fasting plasma glucose of 132. So the patient was diagnosed with diabetes, with the fasting glucose above 125 and an A1C above 6.5. The hemoglobin A1C above 6.5 is now often used by some individuals to make or to confirm a diagnosis of diabetes. While there are some caveats regarding this level, and many of us feel that a glucose tolerance test may in fact be more definitive, leaving the hemoglobin A1C as a screening tool. Now we know that type 2 diabetes gives a high risk for cardiovascular events. What this slide shows is the 7-year incidence of cardiovascular events. And what you'll notice, we're looking at myocardial infarction, stroke, and cardiovascular deaths. Now, if you look at myocardial infarction, if you had a previous myocardial infarction, then you have, in blue, many-fold increase of a future myocardial infarction. And what you'll notice is that even in the absence of a myocardial infarction, in the yellow bar, you'll notice that diabetes gives you the same risk as a previous myocardial infarction for developing a future myocardial infarction. On the other hand, if you've had a myocardial infarction and you have diabetes, your risk goes up so much more. And similarly, you'll see that with stroke and cardiovascular deaths, diabetes by itself is a risk factor for these future events. And if you've had a previous event and you have diabetes, you increase your chances multifold. We call it the ticking clock hypothesis, suggesting that any glucose abnormality will increase the risk for cardiovascular disease even before the diagnosis of diabetes. So in the Nurses' Health Study, you'll notice that if you had no diabetes, and that's set at 1, your relative risk of myocardial infarction or stroke is, of course, 1. If you've had an elevation in your glucose even before we can make the diagnosis of diabetes, your risk goes up 3-fold, and after the diagnosis goes up almost 4-fold. And if you've had diabetes right at the baseline, then of course it's up 5-fold. So glucose abnormalities increase cardiovascular risk. Now, what's the evidence that early aggressive therapy is beneficial in type 2 patients? The evidence comes from the UKPDS, United Kingdom Prospective Diabetes Study, as well as the follow-up, which occurred many years after the trial. So the UKPDS enrolled treatment-naive patients with type 2 diabetes and randomized them to an intensive arm, a standard treatment arm, and the drugs, of course, that were available for use in the intensive treatment arm as well as the standard treatment arm were Metformin, Sulfonylureas, and insulin. Throughout the trial, the intensive treatment arm maintained a difference of 1% hemoglobin A1c. After 10 years of the trial, there was a significant reduction in microvascular disease. While there was a reduction in cardiovascular outcomes, it was not statistically significant, and so was noted as a trend. Then what was done is the patients were allowed to follow up for the next 15 years after the trial. And as it happens, the hemoglobin A1Cs were now the same. And despite that, as you'll see in a moment, there was a reduction in cardiovascular disease, suggesting a legacy effect, suggesting that the intensive group during the trial, even though they were allowed to become less intensive post-trial, actually had less cardiovascular disease 15 years post-trial. So this slide will show you the legacy effect of early glucose control. The left side is 1997, which is the end of the trial, and 2007 are many years after the trial is over. And what you'll notice is that any diabetes-related endpoint was decreased both because of the trial and in the follow-up post-trial. Microvascular disease, similarly, was decreased by 25% in 1997 and remained like that in 2007, suggesting a legacy effect. Myocardial infarction, which I mentioned, was reduced by 16%, but was only borderline. It was 0.052, which is not quite statistically significant. But then if you wait 10 more years, you'll see the legacy effect, that the same 15, 16% was now significant. So that all-cause mortality reduced to 13%, by 13%, and that was significant in the post-trial period. Now, during the trial, you'll notice that there was loss of glycemic control, no matter what medication you used. So if you follow the blue line, you'll see that over the 10 years of the trial, conventional therapy, hemoglobin A1c rose from 7% at the beginning to almost 8.5%. Whether you use glyburide, chlorpropamide, metformin, or insulin, all of the individuals had hemoglobin A1Cs coming down to 6.5% approximately during the first year or two. But then with time, the hemoglobin A1C rose over the 10 years while remaining about 1% lower than the conventional group. This is probably due to the progressive disease that we are dealing with. Interestingly, in the post-trial, when we look at the hemoglobin A1C, you'll notice that in 1997, there was a significant difference between the intensive treated group in red and the conventional group in blue. Post-trial, as we described, over many years, the hemoglobin A1Cs followed each other. And despite that, during this period, we had this legacy effect. So the treatment during the trial left a benefit even 10, 15 years later. And here are some of the data. So when we look at the UKPDS follow-up, we look at any diabetes-related endpoints. If you look at sulfonylureas and insulin group, you look at the metformin group, and you compare conventional therapy in orange to the treated therapy in blue dash or green dash, you'll notice a significant difference over the years, suggesting that intensive therapy does help when looking at any diabetes-related endpoint. When you look at microvascular disease, it's clear-cut. The red is during the trial and the blue is post-trial. And you'll notice that each of these points are below the hazard ratio of 1, meaning there was a significant advantage in preventing microvascular disease by intensive glucose control. So here again is the microvascular disease during the follow-up period, conventional therapy versus the sulfonylurea or insulin or metformin on the right-hand side. And you'll see with the intensive therapy with sulfonylurea or insulin, microvascular disease was significantly reduced during the trial, but specifically also after the trial. What about the myocardial infarction? What you'll notice with regard to the hazard ratio of 1, that the red symbol in 1997, which is the end of the 10-year period of the trial, touches the level of 1, and so it makes it statistically non-significant. But then you follow the blue symbols, and you go out to 2007, and the legacy effect is present because we're below the line, and we're significantly below the line, suggesting that indeed myocardial infarction is preventable in the future if intensive therapy is started early. Here again is death from any cause, and you'll see significant reduction using intensive therapy, either sulfonylurea, insulin, or metformin. And you can see the significant reductions in death by using intensive therapy, both during the trial as well as years since randomization, which means including the post-trial period. So we now know from the UKPDS that there are benefits of glycemic control. For every 1% reduction in A1C, there's significant reduction in complications. The risk of myocardial infarction goes down, as shown in the post-trial period. The risk of diabetes-related death, the risk of microvascular disease, and the risk of amputation or peripheral vascular death. So a reduction in glucose and A1C during or after the trial led to improvements in both microvascular and macrovascular disease. So to summarize, after 10 years of the trial, there was a significant reduction in microvascular disease, but no statistical difference in cardiovascular outcomes, although a trend was noted. In up to 15 years post-trial, during the follow-up, despite no differences now in hemoglobin A1C between the two groups, there was a significant difference in cardiovascular events, suggesting a legacy effect. The legacy effect, or this metabolic memory, was also very similar to that seen in the DCCT trial, which is the type 1 diabetes trial. And so in that trial, where type 1 diabetes was treated intensively or not, they also noticed years later that macrovascular disease was reduced, probably because of the intensive therapy during the trial. So these outcomes have been interpreted to suggest that early intensive therapy in diabetic patients prior to the development of macrovascular disease is critical to the long-term outcome. And I want to emphasize here that in type 2 patients, this intensive therapy should begin when we diagnose the patients with diabetes. Because if we wait 20 or 30 years while cardiovascular disease develops in these patients, and then we try intensive therapy, this could be deleterious. So let's look at the natural history of type 2 diabetes, because this will tell us something about the disease as well as the complications. If we look at the date or the years at the top, -10, -5, 0, these are approximate years prior to the diagnosis of the disease, and then 15 years later after the diagnosis. The disease probably begins 5 or 10 years prior to our making the diagnosis. And during this period, we know that insulin resistance is present. It either increases because of increased weight, aging, etc., but it's always there. Insulin resistance is a sine qua non of the disease. The beta cell tries to overcome this resistance by secreting more insulin. So you'll notice in orange the rise in insulin secretion. But from the time that we make the diagnosis of the disease, we already know that there is inadequate insulin secretion, and it continues to decrease over a period of the post-diagnosis life of the individual. And we suggest that beta cell function is what's deteriorating over time, as shown in the purple line, and it deteriorates relentlessly all the years after diagnosis. And it's this deterioration in beta cell function that actually is the reason for the progression of the disease. Now, when we look at the diagnostic criteria, when we look at what first goes wrong with a patient, it turns out that postprandial glucose rises first. Fasting glucose only rises at about the time of the diagnosis or soon thereafter. This is an important point because our diagnostic criteria of just looking at a fasting glucose on a blood sample when the patient comes into the office is totally inadequate. We're missing 5 years of diagnosis if we'd only measured postprandial glucose. And that's why many of us feel that the hemoglobin A1C of 6.5 cutoff is clear-cut. Anything above that is diabetes. But what about the patients who are between 5.8 and 6.5? If we measure their postprandial glucose, or if we do a glucose tolerance test, we would pick up the diagnosis much earlier and begin treatment much earlier. This onset of diagnosis prior to what we count as diagnosis today is the reason why individuals develop microvascular complications so early. And furthermore, macrovascular complications begin even earlier than that. Not surprisingly, we sometimes have patients admitted with a myocardial infarction, coming to see the doctor with diabetic neuropathy, and only then we make the diagnosis. The disease began earlier, but we are missing the diagnosis because we are looking only at the fasting glucose. Type 2 diabetes, as I said, is a progressive disease. We have the pre-diabetic state where we could pick up impaired glucose tolerance if we made that assessment. And the way to do that is to take the family situation, take a good history, a good examination. Anybody who has a family history of diabetes, anybody who has hypertension, anybody who has a high triglyceride, low HDL, anybody who's overweight, all of these could have pre-diabetes. And we can pick that up by doing a glucose tolerance and getting numbers that show impaired glucose tolerance. We know that many of these patients move on to develop type 2 diabetes, and many of them, of course, develop complications. So we could prevent, primary prevention of diabetes is catching the individuals during the pre-diabetic state. Secondary prevention is by decreasing the impact of type 2 diabetes and slowing down the progressive disease. And of course, tertiary prevention is to prevent the complications. So as we said, diabetes is a progressive disease, and the UKPDS, which is shown again on this slide, shows again how conventional group of patients, when they're treated with conventional therapy, the hemoglobin A1C from onset at 7% goes up to above 8. The treated patients have an initial response, which is very nice, but they eventually will also deteriorate and their A1C levels will start to climb in parallel. Even though there's a 1% difference between intensively treated and conventionally treated patients. Everybody will progress because it's a progressive disease. Furthermore, we also know that patients spend a lot of their day in a postprandial state. And what's shown in this slide is breakfast, lunch, dinner, and then we go on through the night. The fasting really only exists from about 2, 3 in the morning until breakfast. Because after breakfast, we have a post-absorptive state where the blood glucoses are elevated in our patients. Then they go into a postprandial state. Once they eat lunch, the same is repeated, post-absorptive, postprandial, and after dinner the same. So patients are seldom fasting. Most of the time, they're in this postprandial or post-absorptive state. We also know that patients remain on monotherapy for too long. This particular study shows that if you look at the number of months that patients are on monotherapy and are running at a hemoglobin A1C of above 8, before additional therapy is given, you'll see that those on Metformin, which is our first drug of choice, can go on for 15 months before they have a second agent added. Patients on Sulfonylureas traditionally can go on for almost 2 years purely on one medication. And obviously this is inadequate. And so our treatment titration for type 2 diabetes, shown on this slide, is obviously diet and exercise to start, because weight loss is very important. Exercise helps, and this is very important to start the patient on lifestyle modification. But we should initiate oral combination therapy sooner than we do. We shouldn't stay on monotherapy for too long. We should institute combination therapy very quickly. And of course, we know most of our patients will progress into injectables, classically insulin, although there are incretins as well, and often combination of injectables with oral medication. So why use early combination therapy? Combination pharmacotherapy addresses multiple pathological defects. So we have drugs that work on the beta cell. We have drugs that work on insulin action. We now have drugs that work on gastric emptying, on appetite, etc. All of these are abnormal pathological defects and can be addressed by multiple different therapies. Dual therapy can be titrated, and it's better to do it simultaneously than sequentially. So an early stepwise titration can allow you to aim at your glycemic target. But of course, the medication should be titrated based on the glucose patterns, whether you use fasting or whether you use a postprandial agent. And this is important because the clinical implications of postprandial glucose control has been shown to be very important. Postprandial glucose reflects an important pathological process of the disease, namely beta cell dysfunction. In addition, the impact of postprandial glucose on total glycemic excursions are often very more important than fasting plasma glucose at target A1C values. So as you reach a hemoglobin A1C of, say, less than 7, the hemoglobin A1C at that point is mostly postprandial. It reflects insulin secretory response of the pancreas to the meals, and of course, postprandial glucose is determined by whether we can suppress hepatic glucose production and whether we can dispose of glucose into the muscle. So it's very important to control postprandial glucose. It may also have some deleterious effect on the cardiovascular system. So this slide, which is adapted from a study by Del Prato, looks at the question of early, more aggressive intervention in terms of improving patients' chances of reaching the goal being hemoglobin A1C. You can see that a hemoglobin A1C in green of 6.8 would be something that we'd like to achieve. In other words, less than 7 and maybe even a little lower. In blue, you can see what's actually happening. We start with diet and exercise, and the patients who respond, their hemoglobin A1C theoretically could come down from 9 to 7.5. But after a few months, it goes up again, so we add monotherapy. It comes down. After a few months, the A1C goes up, and we up-titrate the monotherapy. We then move on to combination therapy. We then move on to injectables and combination therapy. And eventually, patients, because of the progressive deterioration of the beta cell, may require multiple daily insulin injections, the basal bolus concept, for example. This takes many years. This can sometimes take, in some patients, depending on the physician and the patient, this can be progress over 10 years. And what we'd like to do in this slide is to show how we can move the whole process earlier rather than 10 years, within a few years. So monotherapy, which reduces, shown in green, very nicely at the beginning, we should titrate, we should add combination therapy within a few months if monotherapy is inadequate. And we should move the whole process to the left. We shouldn't let it be drawn out to the right over 10, 15 years. We should, over a year or two, compact the whole process and basically reach our goal much faster and keep the patient at the goal. So the basic principles of anti-hyperglycemic drug selection is we'll choose the agent to be used in a given patient depending on differing side effect profiles of the various agents, and we'll discuss how weight increase and hypoglycemia are the two side effects we really want to avoid. We'll also use the agents that will give us the best degree of glucose lowering that's required. And as I said in the previous slides, intensification of therapy requires monitoring and medication adjustment every 2 to 3 months. We do a hemoglobin A1C every 2 to 3 months because that enables us to see how we're progressing and to change the medication, and not to wait a year, 18 months before adding a second medication or up-titrating the first medication. So the key points to consider when selecting pharmacotherapy for type 2 diabetes, we have to look at the history and duration of type 2 diabetes. As we said, early in the disease, intensive therapy is appropriate. Very late in the disease, be careful with intensive therapy because you can precipitate side effects and deleterious outcomes. We want to look at the blood glucose level. If it's not a target, we want to look, is it the fasting that's not a target, or postprandial, or both? And according to that, we'll select the pharmacotherapy. Patient's preference, whether it's oral, injectable, these may count. The degree of A1C lowering to achieve the goal, as we said, the side effect profile, and patient's tolerability. And then, of course, very important, as the disease progresses, cardiovascular disease, if the patients have depression, osteoporosis, we will then adjust medications according to that because some of the medications have effects on these various conditions. Now, in combination therapy with oral agents, the rationale for choice is we want drugs that target different metabolic defects, be it the pancreas, the beta cell, be it the insulin action, be it the gastric emptying, be it the excessive glucagon, which is causing hypoglycemia. All of these will be rationale for different choices. And also, we will target fasting and postprandial glucose control. We also have to take into consideration, as I said, multiple metabolic defects, the polygenic basis of the disease is progressive. We know the limited efficacy of single agents, and they may only last for a year or two. We also know that hypoglycemia begets hyperglycemia, so that allowing the chronic hyperglycemia to persist for too long has effects on the various organs. High blood glucose levels affect the beta cell function. They affect insulin action at the target tissue. So we have to take all of this into consideration. So let's turn to incretin therapies. These are the new agents that we've started using, and there are two major forms. They're the oral DPP-4 inhibitors. The ones that are improved are sitagliptin, saxagliptin, and linagliptin. We have the injectables. These are the GLP-1 mimetics. And the ones that we have available are the first, which was exenatide, twice daily. We have the liraglutide, which is once daily, and exenatide extended release, which can be given once a week. And this slide shows how the incretin effect works. As we eat a meal, we will have release of GLP-1 from the intestine, from certain cells. This will increase the active GLP-1 in our system. The active GLP-1, unfortunately, gets inactivated within 2 minutes by a DPP-4 enzyme. And that's where the DPP-4 inhibitors work, by preventing the endogenous GLP-1 from becoming inactivated too quickly. Our injectables, of course, replace the GLP-1 that we would normally release after the meal. And the effects of these incretins, be they the oral agents, the DPP-4 inhibitors, or the GLP-1 receptor agonists, which are the injectables, there's certain similarities. They will both increase insulin synthesis and secretion and improve beta cell function. They will both reduce glucagon, which will then lead to a reduction in hepatic glucose production. There are differences between these two groups, however, shown in the bottom of the table, in that the injectables will increase weight loss. They will reduce appetite, reduce gastric emptying, but of course, at the expense of having adverse gastrointestinal effects, which the DPP-4 inhibitors, the oral agents, do not have. What's very important with these incretins, be they the orals or the injectables, is that they seldom cause hypoglycemia. And the reason is that they have glucose-dependent mechanism, whereby when the glucose falls, they stop working. And that's very important because we have other agents like sulfonylureas which commonly cause hypoglycemia. So let's ask the question. DPP-4 inhibitors and the GLP-1 agonists have the same properties as I described, except which of the following? Do they both increase levels of circulating GLP-1? Do they both suppress appetite? Do they both reduce hemoglobin A1c? And thus far have a lack of significant cardiovascular side effects. Which is the correct answer? Well, it turns out it's appetite suppression. The GLP-1 receptor agonists, the injectables, do suppress appetite. The DPP-4 inhibitors do not. However, what's also important is the fourth line. There are no significant cardiovascular side effects in either of these two agents. Now, we discussed earlier trying to prevent diabetes because we know that there are many individuals who are diagnosed or could be diagnosed as prediabetes who will then progress onto diabetes. Well, obviously, lifestyle change, diet and exercise, could prevent this in many of the patients. Weight loss could reduce patients with prediabetes becoming diabetic. And of course, that's important because when you become diabetic, your chances of complications increase dramatically. There are pharmacologic agents that have been tested, Metformin, the alpha-glucosidase inhibitors, and the thiazolidinediones. Each of these have been shown to also reduce the progression to type 2 diabetes. However, none of them to date are FDA approved for this indication. Now, this slide shows you some of the data suggesting that there is a reduction in diabetes developing from prediabetes. Whether you look at thiazolidinediones, biguanides, alpha-glucosidase inhibitors, all of these, except for sulfonylureas, do have a reduction. And the way to read the slide is the line that sits across the number 1, that's no change, whereas everything that moves to the right and doesn't touch the line, as shown with the boxes, actually suggests that there is a reduction in diabetes progression with the use of these agents. Let's return to the rationale for combination therapy. We spoke earlier about fasting hypoglycemia or targeting postprandial hypoglycemia. So the left side of the column, metformin, sulfonylureas, TZDs, insulin, and bromocriptine and other agents all affect fasting hypoglycemia. On the right side, you'll see all of the agents that affect postprandial, the short-acting insulins, pramlintide, alpha-glucosidase inhibitors, glitinides, DPP-4 inhibitors, and the GLP-1 agonists. So when one chooses to reduce fasting glucose or postprandial, one can choose from either of these two columns, and of course, they can be used in combination. So let's return to our patient, the 42-year-old obese man recently diagnosed with type 2 diabetes. He was started on a low-dose metformin with dose escalation over a few weeks. The reason for that, you'll remember, or you've experienced, metformin has some gastrointestinal side effects. And if we tell patients to start on a low dose and gradually escalate over a period of weeks or even 2 months, the side effects can be minimized. So at 3 months, his hemoglobin A1C fell from 6.9 to 6.4, and he had some slight reduction in weight due to the metformin, perhaps also from some lifestyle change. At 1 year, his control worsened, even though he was on a maximum metformin 2000. And the regimen was intensified by adding a DPP-4 inhibitor to the metformin. And because he's relatively young with no obvious cardiovascular disease, the decision was made that an intensified treatment regimen was best for him. So what are the major concerns with therapy? I mentioned this before. Patients are very worried about weight gain. Many are already obese or overweight. And the hypoglycemia is devastating. So agents that can control or reduce weight while avoiding hypoglycemia and reduce hemoglobin A1C are preferred over many of our existing therapies. And these newer agents, such as the incretin family, are weight neutral if they're DPP-4 inhibitors, or weight reducing if they are the GLP-1 injectables, and used in combination with existing therapies are actually a very exciting new development. So obese patients with type 2 diabetes may lose weight with all except which of the following therapies. Let's choose which of the following therapies help lose weight except for one: metformin, bariatric surgery, GLP-1 agonists, the injectables, or sulfonylureas. And I think everybody knows the sulfonylureas do not help you lose weight. In fact, you often put on weight on a sulfonylurea. Now, weight loss drugs have been approved by the FDA and have started in 2012, 2013. And there are two that have recently been approved. There's the topiramate phentermine, which combines an anticonvulsant and an appetite suppressant, and the average weight loss in the first year, 14%, with some sustainability. There's leucoserin, which selectively activates the serotonin 2C receptor and increases satiety. Average weight loss, 6% of body weight, with some sustainability. So we do have two agents that can help reduce weight in patients who have difficulty doing it with lifestyle change. Another question. GLP-1 agonists of the following proven characteristics except which of the following? Significant reduction in appetite, delayed gastric emptying, weight reduction, reduction in hemoglobin A1C, and reduce long-term cardiovascular complications of diabetes. Which one is not a result of the GLP-1 agonists as of today? The answer is the last one. So GLP-1 agonists reduce appetite, delay gastric emptying, there's weight reduction, and of course, a reduction in hemoglobin A1C. But thus far, it hasn't been shown that they reduce long-term cardiovascular complications of diabetes, although we're anticipating that perhaps in the future, the trials will show this effect. So in conclusion, early aggressive intervention can result in improved glycemic control. Better control reaps long-term benefits in reducing both microvascular and macrovascular complications, the so-called legacy effect. Early intervention in prediabetes, including the off-label use of FDA-approved drugs, may not only prevent progression to frank diabetes, but also result in regression to normal glycemia. Thank you very much.
Thank you, Dr. LeRoith, for that thoughtful review of the rationale for the early, more aggressive approach to the management of patients with recent onset type 2 diabetes. Permit me to underscore the major take-home messages for our audience. First, the recognition of the so-called ticking clock, namely that even the years prior to the diagnosis of diabetes, the pre-diabetic state already puts the patient at risk for development of both microvascular and macrovascular complications. Second, the concept of the legacy effect, possibly better termed metabolic memory, as evidenced by the UKPDS experience. It seems clear that earlier, more aggressive therapy results in better long-term micro and macrovascular outcomes, even if future control worsens. So how do we approach this type of patient? First and foremost, there must be an educational component with focus on diet, weight loss, and exercise. The clinician and patient both must recognize that taking a too little, too late denial approach to a silent disease is counterproductive. Accordingly, the early introduction of a single agent, usually starting with Metformin, up-titrating at weekly intervals to full doses as tolerated, 2 grams per day, divided with meals, or once daily as an extended-release generic formulation. Highly recommended is frequent follow-up at 2 to 3 month intervals, adding a second-line agent with a complementary mode of action if hemoglobin A1C and blood glucose targets have not been attained or maintained. Recent American Association of Clinical Endocrinologists guidelines available online at their website simply states, and I quote, "Intensification of pharmacotherapy requires glucose monitoring and medication adjustment at appropriate intervals when treatment goals are not achieved or maintained. Most patients with an initial A1C level greater than 7.5% will require combination therapy using agents with complementary mechanisms of action. Whether or not one makes use of combination formulations currently available, or, as I generally do, add a second agent, is a matter for doctor and patient preference. Since type 2 diabetes is usually progressive in nature, continued follow-up, encouragement, and motivation for patient adherence is clearly required. The ultimate need for one or more additional agents, oral or injectable, will require individualization. The newer agents, the oral DPP-4 inhibitors and the injectable GLP-1 agonists, avoid the issues of weight gain and hypoglycemia seen with the much less expensive sulfonylureas. These incretin-related agents also appear to have a more durable effect. However, as pointed out by Dr. LeRoith, their long-term efficacy regarding cardiovascular protection will have to be demonstrated. Before closing, I would strongly recommend that the interested clinician be made aware of the recent website provided by the American Association of Clinical Endocrinologists called the ACE Diabetes Resource Center. It provides a comprehensive overview and management principles of both type 1 and type 2 patients, as well as diabetes in pregnancy. Finally, on behalf of myself, Dr. LeRoith, and the Cleveland Clinic, I wish to thank you for attending this virtual Grand Rounds session.